segment available. What I'd also like to kind of remind you is do not forget to kind of remember the code words, which I'll give you one at the end of the first segment. In the end of the second segment, you'll get the second code word, and you need to put that in for your attendance. Okay, so we are good to go. Okay, so a very good morning once again. Thank you so much for joining us for this year's first session of the SK Dharmalingam series. And for us today, we're very excited because we have actually someone who's very connected to the SK Dharmalingam family. So it is Dato Dr. SK Dharmalingam's daughter, Dr. Saunthari, who is our president of the National Cancer Society of Malaysia, as well as our speaker for this morning. So I would actually like to introduce Dr. Saun. Hi, Dr. Saun, good morning. Do you want to say a few words?
Morning, everyone. I think
okay.
Murali here wants to tell all my secrets as we go along.
No, not at all. So yes, so actually we just, it's always lovely, I think, when we started the series to kind of have people, we had a couple of people who actually worked with your dad previously. So it was nice of them to kind of give us little, how to say, glimpses into how he was as a person as well as a physician. Really, so this is the time for the goss, really. So how was, wanted to ask you actually, so how did he kind of put out the national cancer? How was this whole baby born?
Wow, okay, this whole baby was really born the year I was born, actually, which tells you how old I am. But it was because he couldn't move things fast enough within the government service. They had started the cancer services in Hospital Kuala Lumpur at the time, GH at those days. And there were a lot of things that he wanted to do. But because of the bureaucracy and whatnot at the time, he couldn't do everything. So he decided to start the National Cancer Society of Malaysia so that it could work side by side with the government services and provide those integral services that were required quicker than what we could do within the government service. So we were really started to complement the government services for cancer.
Right, and I think safely saying it's a job that we still like kind of continue doing today. I was just curious though, how much has this kind of grown, changed over the years or the decades since he actually kind of started it? And what would he think if he got up this morning and walked in?
That one I'm not sure. My father and I had dissimilar interests in terms of cancer services. As mentioned, he was the first radiotherapist oncologist in the country. And so he was very much clinically based. The whole idea was to treat and to ensure that we could find cancer earlier and we could do something about it in a clinical manner. Whilst when I came on board, I came from a different perspective. And I think my father's perspective changed as well when my mother got cancer. My mother was a driving force in terms of how the cancer services of the National Cancer Society changed. And primarily it's because we learned more that, as doctors, we tend to just focus on the disease and not as the patient holistically. And that's what changed with the National Cancer Society as well, is that, in the early days, we focused very much on the disease, on making sure that we could find cancer earlier, we could treat cancer better. But as we went along, especially in 2000 plus, we looked at it more in a holistic manner, that we're not just treating the disease, but we're looking for the welfare of the patient as well. So it was more holistic aspect of that. The disease is not everything, it's the person who is everything. And so we became a lot more patient-centric in terms of our services. And that's why we have more of the complementary therapies which go on in the National Cancer Society in Malaysia, the counseling, et cetera, et cetera.
Right, but something I do actually recall looking through all the work that we've done over the years is that we have remained very faithful to the idea of education and especially education of doctors and other health professionals, haven't we, Dr. Sam?
Yeah, that one hasn't changed. I think that was the key focus when we first started, and it still is very much a key focus of today. And the whole idea is to actually build resources, is to build a network of people who are interested in cancer and who play a part in that journey that a cancer patient has.
Right, and I think one of the, just to share with you, ladies and gentlemen, I think that's one of the reasons why we restarted the SK Dharmalingam series as on a much more intensive manner. So now it goes on every month, and really one of the objectives of this series is actually to reach across to primary care physicians and put in the understanding, the insights, and the kind of also perhaps to put on a little bit of added responsibility into primary care physicians, into taking on roles in managing cancer within our population. And today, to make this case a little stronger and maybe launch 2021, we just had our World Cancer Day on the 4th of February. So this is, we feel, a really good session to start the year on, is talking about survivorship and managing survivors in the primary care setting. So without further ado, please allow me to turn the screen over to Dr. Sound, who will take us through these two segments this morning pertaining to this. Dr. Sound, screen's all yours.
Thank you. Thanks, Dr. Murali. So yes, today we're going to talk about survivorship and how integral the primary healthcare service is to the idea of looking out for cancer recurrence and survivorship issues as well. We've divided the talk into 4 sections. Okay, let me see here. Sorry, I'm using a different computer, so I am trying to go down the page. Sorry. Help is coming now. So as I mentioned, we're talking about 4 aspects of it. The first aspect of it. Do I go back? Okay. So the first aspect of it that we're going to talk about is just the general aspects of cancer survivorship. And the second part of the talk today is more in terms of what's happening in Malaysia and what we'd like to happen in Malaysia. So generally in terms of cancer survivorship, there are many different definitions out there. But if you look at the definitions which are out there, it basically all says that you are a cancer survivor from the moment of diagnosis and the remainder of your life. So irrespective of whether you're being treated or you're not being treated, you are a cancer survivor. And if you look at the middle one, that goes further to say the impact of cancer on family members, friends, caregivers, or survivors is also acknowledged as part of survivorship. So in Malaysia, who is a survivor? There's a huge common misconception who is a survivor in Malaysia. Even most of our medical fraternity think that a survivor is only a person once they have finished treatment. And that actually stops a whole group of people getting the support systems behind them whilst they are being treated for cancer. So it's very important for all of us to acknowledge that a person is a survivor from the point of diagnosis till the end of his or her life. And this is commonly divided into 3 stages of survivorship, which is the acute. And this is when people don't, as I mentioned before, a lot of people don't think of survivors as in this phase, which is the acute phase, which is which begins at diagnosis to the end of initial treatment. So though the main focus here is on anti-cancer treatment, it does not mean that the person, the survivor, does not need other aspects of cancer support as well. The extended aspect of survivorship begins at the end of the initial treatment to months after. So this generally looks at about 2 years, really, from the point of the end of your extended care. The main focus is on the effects of cancer and its treatment. And then you have the permanent, which refers to the years after anti-cancer treatment. And again, this is the main focus is on the long-term effects of cancer and the treatment as well. Another way of looking at it is looking at the extended framework. So you've got the acute survivorship, transitional survivorship, extended survivorship, which is your maintained survivorship. Oops, sorry. Yeah, so you've got your extended survivorship, which is cancer-free, and extended remission, where you're actually still living with cancer. And then it goes into the permanent survivorship aspects. So when you look at acute survivorship, it's the same as before. It begins at the moment of diagnosis and extends throughout treatment. And common symptoms here that affect survivors in the stage often include nausea, pain, as well as anxiety and depression. And it's really important for the anxiety and depression aspect of it to be cared for. We tend to care for the clinical aspects, which is the nausea and pain, but anxiety and depression is something which, if you can look after from day one, it helps in terms of just not treatment, but it helps in terms of overall survivorship. Transitional survivorship is from the initial phase of diagnosis and treatment has ended, and when you go back to a new normal. So this again is a time where a patient who's had all the attention on them suddenly is left to fend on their own. And so there's huge feelings of isolation and depression during this time of how do I get back to the new normal? And your extended survivorship is disease-free following treatment, but you still have various risk of recurrence. And as you go along, of course, the risk decreases. Survivorship is a very heterogeneous group. So some are cancer-free and free of cancer. And that's two very different things, because cancer-free is just that physical aspect of not having cancer, but free of cancer is looking at either the physical and emotional impact of what cancer has had of you. And the second part really is some remain in the stage, but some might re-enter the stage of acute survivorship because of a secondary cancer caused by the therapy for their original cancer, or while they just relapse. And others might develop a second unrelated cancer. And this is the stage that we can do quite a lot about in terms of relapse and looking out for the signs and symptoms associated with it. So if you move along to survivorship statistics, these are the survivorship statistics that we see from the US. And as you can see, all I wanted to show with this slide is that you can see that survivorship has been charted from a long, long time ago. So they have survivorship statistics for over 50 years. And as you can see, survivorship is increasing dramatically as we go along. And this is due to two main things. One is the earlier detection of cancer. And two, the second part of it is better treatment options, which are out there. In Malaysia, however, we don't have a nice chart like that. We have only been tracking survivorship since 2014. So what you see on your screen now is really a compilation of survivorship for the last 5 years up to 2018. And what you see here is about 20% of survivors are between the ages of 15 and 44. 50% of survivors are between the ages of 45 to 65. So if you look at that, that's 70% who are young or who are still within the working ages. And this is very, very important to ensure that the survivors who are out there within those groups are still able, within the new norm, to be able to be active members of society, whether it be work or at home as well. And then if you see there as well, 20% of survivors are between the ages of 65 and 74. And here you will see 20% of survivors between that age are survivors who also are going to be having comorbidities and are going to need extra care in terms of long-term chronic disease. Lastly, looking at childhood cancer statistics as well, children and young people with cancer are going to have many, many more years of survival, but they have to contend with, one, the risk of recurrence, two, the new onset cancers, and the late or long-term effects of disease or treatment. And the late or long-term effects of disease and treatment are quite enormous in terms of cognitive defects, as well as in terms of heart and other organs. This slide again is from the Malaysian study of cancer survival MyScan. It'll be good for you to actually go through the MyScan because there's a lot of information out there. But what I wanted to show with this slide is your 1-year survivor, which is the light pink, and the 5-year survivor. As you can see, with the 1-year survivor, we're actually quite good. But when you look at the 5-year survivorship, it actually drops back dramatically. And this is really an indication again on how, at what stage we are actually diagnosing cancer. And unfortunately, cancer is being diagnosed at very late stages, primarily in stage 3 and stage 4. And because of that, we're not getting that long-term survivorship, irrespective of whether they have treatment or not. And that's very important because that lies within the primary healthcare sphere as well in terms of the early detection and also looking at the signs and symptoms of relapses. Just to take an individual example, if you look at female breast cancer here, this is the 5-year relative survival. As you can see, Malaysia is 66.8% compared to all the other countries there. And this, as I mentioned again, is one because of later detection. Most of breast cancer in Malaysia is diagnosed in stage 2, stage 3. But it is also an indication of the care that the patient gets post-treatment, whether or not recurrences are being picked up fast enough, the psychological issues that a breast cancer patient faces, whether or not patients are lost in transition. So there are a lot of elements which play into survivorship in the long run. Having said all that, this slide is really to show how long survivorship is. So if you look at for cancer of the cervix, the mean number of years is 3.84 or 46 months. Ovary, 64 months. So these are many years that cancer survivors are going to be in the community and out of a tertiary setting in terms of their treatment. And this is really where the primary healthcare is so important in terms of ensuring that that cancer survivor has the best quality of life through specific care and consideration of their psycho-emotional issues. So as you see with the more common cancers like prostate, there's 58 months, nasopharyngeal, there's 40 months, and lymphomas as well. There's a good number of extended survivorship in all these cancers. And it will only get better as we move along. So in terms of survivorship issues that people might have, This is a painting and the words of Michel Angelo Petron, who was a cancer survivor who passed away from it. But he actually tracked his cancer survivorship journey. And one of the things he said was serious illness, such as cancer, changes everything that is familiar in our lives. The world, as we know, changes overnight. It is difficult to understand what is happening, let alone what you are feeling. Another thing he said was outcast, marginalized, ostracized. I wait alone to find out if I have cancer or what. Will I fall to the ground or will someone catch me in time? And this is something which I think every single person who is diagnosed with cancer goes through. And it demonstrates how important it is that we as the medical fraternity are there to catch someone, to ensure that they're not lost, that they don't fall to the ground, and that we help cancer survivors understand what is happening and help them with the feelings that they go through. So this doesn't just include, as I mentioned before, when I was talking about the difference between how we used to look at cancer in the 1960s or up to the 1980s to how we look at cancer now. It just doesn't look at the physical manifestation of cancer, but it includes the mental, the emotional, the social, the financial effects of cancer that begin at diagnosis and continue beyond treatment. And so, as I mentioned, it's very important to see a person with cancer as a survivor from the time of diagnosis, because all these issues, whether it be physical, mental, emotional, social, financial, all happen at that point of time. Also included into the issues with survivorship are related to follow-up care, including regular health and wellness checkups, the late effects of cancer treatment, cancer recurrence, secondary cancers, quality of life. And here, it's also important to include not just the survivor, but the family members, caregivers, and friends as well. This is just a map to show you all the different things that can impact a person with cancer. So if you look at the outer ring with the darker colors, that's the potential long-term and late effects of cancer. Fatigue, sleep problems, fear of recurrence, anxiety, depression. Those are very, very real and common impacts that a person with cancer lives for the rest of their life with. Things like peripheral neuropathy, especially with your breast cancer cases, hot flushes, osteoporosis, sexual dysfunction, etc., bowel and bladder dysfunction with your prostate cancer. So there's a huge number of issues which then impact the cancer survivor and gives them or makes them question their reason for living. So they have psychosocial issues, economic problems, loss or change of employment status, struggling for meaning, spiritual issues, social isolation, role disruptions. And many doctors don't think that, this is under their purview, that this is something that we as the medical fraternity should be looking at. There are other people to look at these things. The answer is yes and no. A lot of these things come from not understanding the physical manifestations of cancer. And if we can deal with those physical manifestations of cancer, we can actually diminish the psychosocial issues that people have. So it is a problem shared between the medical fraternity as well as those in the aligned healthcare, such as your counselors, your social workers, the community at large, etc. This is another of Michelle Angelo Petroni. I'm very confused. I'm lost as which way to turn and who to turn to. And I think what's poignant about this is who to turn to. As I mentioned, we as doctors aren't really taught to look beyond the physical manifestations of a disease. But it's important as a doctor that we provide professional support. And that professional support has to be beyond the treatment aspects of it. And unfortunately, in Malaysia, there's a lack of definitive best practice guidelines in caring for survivors. So many survivors are lost in transition, whether they're newly diagnosed, whether they're going through treatment, and because of depression, because of loss of faith, they decide to leave treatment or even post-treatment. They're lost in transition, as if you remember rightly, when you talk about survivorship, you're talking about the acute phase and then a transitional phase. So they're lost from the oncology setting to the primary healthcare setting. So when they finish their initial treatment to when they get into the primary healthcare setting, they get lost. You get delays in treatment, compliance to treatment, follow-up. And all these can be helped by having good cancer care plans, because it honestly facilitates communication and it puts issues into perspective. So cancer care plans talk about the type of cancer, the treatment which should be given, the short, long-term side effects of the cancer. It assists in the navigation of your cancer journey. And it also takes into account survivors' values and preference of care. So it becomes very much patient-centric and not disease-centric. And that's, I think, the key to cancer survivorship. That whatever plan is out there for an individual, it is centered on them as a person with an identity and not on a disease specific to an organ. The professional support is also, as I mentioned, beyond treatment, it's unmet needs. So the unmet needs are medical, functional, psychosocial consequences of cancer and its treatment. As the map showed earlier on, you have sexuality issues, especially with breast cancer, cervical cancer, prostate cancers, and even colorectal cancers. There's distress, chronic pain, fatigue. And here your chronic care model makes a difference because it's a system-led intervention. So it takes into account the patient, the provider, and the system pushes the interventions forward. It addresses the psychosocial, the lifestyle, the physical problems to improve clinical outcomes, the psychosocial assessments, holistic needs assessments, healthy lifestyle interventions, dietary interventions, etc. So this is the gold standard when it comes to cancer survivorship and how do we actually care for cancer survivors. One of the ways of looking at it is in the management of survivorship. You've got the cancer survivorship post-treatment phase, which then is divided into prevention for survivors and family, and the promotion of healthy behavior, physical activity, diet, smoking cessation, etc. So that's the prevention aspect of it. You've got the detection aspect of it. So for survivors, it's the adherence to follow-up care, screening for secondary cancers, recurrence, screening for related comorbidities and conditions, etc. And the family, screening for high-risk families. And when you look through all these things, this is very much in the realm of primary healthcare. This is very much in the realm of the family physician to be looking out for these things. And the last is the treatment management of side or late effects. So survivors, you've got pain, cognitive function, sleep disturbance, fatigue, sexual dysfunction, organ dysfunction, the family, the psychosocial, caregiver burnout, etc. And all this is very, very much, very, very important in terms of the long-term care and well-being of the survivor and the family and the overall community. Another way of looking at it, as I mentioned, it should be system-led. This is the way you can look at it. This is from the Clinical Society COSA of Australia. And they have this model of survivorship care. And if you go look for it, actually, they actually have a patient statement, which is about 25 pages long, but it really goes through survivorship. It really goes through how survivorship should flow and how patients should be cared for. And it's a lovely document to look at. So as it shows here, number one is the diagnosis. And even at the point of diagnosis, you have to look at the patient, the health literacy of the patient. How does the patient understand what the diagnosis means? So a needs assessment has to be done. And then education, so that the patient then has the opportunity and is empowered to actually be part of the whole system in how their cancer is being looked after. And then you've got the end of primary treatment. Again, the risk stratification, looking at how that patient is enabled to move back into the community, looking at the treatment summary plan related to care plan. How are they going to be looked after? So then you have rehabilitation, again, a needs assessment with rehabilitation, addressing the acute effects of cancer and treatment, whether it be physiological, psychological, social, spiritual, lifestyle, career work, etc. So all this comes into the plan. So it's not just looking at the specific physical side effects of cancer or treatment, but it's looking at the patient holistically. And then you have the follow-up aspects of it as well, looking at whether the risk stratification and needs assessment, whether the patient is low risk, whether the patient has a moderate risk, a high risk, who then looks after that patient in the follow-up care, whether it's just self-management, the patient can do it themselves, or is it professionally led? So if it's professionally led follow-up, is it specialist-led or primary healthcare led? Then you've got the supportive aspect of it, transition of to end-of-life care, palliative care, etc. And then you have the time of the new problem. So timely re-access, remote monitoring, community-led, that's very much within the primary healthcare area. And then primary healthcare, pushing it up to specialists, etc. And then it comes right back again to the beginning. If there is a new cancer, how is it diagnosed? When is it diagnosed, etc. So system-led support system for survivors is complex, and it is multidisciplinary, but it has to be coordinated. And it's there to promote, prevent, and manage cancers, and it should be accessible and equitable. So all this means that every single one of us needs to be involved within survivorship, just not, tertiary level in terms of oncology, just not NGOs like ourselves at the National Cancer Society, where we look at the supportive aspects. It is every layer of healthcare needs to be involved in the support of survivorship. So I think I will end there for the moment to see if there's any questions.
Okay, thank you so much, Dr. Sound. There's a couple of questions, if we can take them. Okay, sorry. I think from Dr. Lu, slides shared after the talk. For sure, Doctor, as you know, the session is recorded, and so the slides will be available as well. We'll send you an email, and the session itself will be available on YouTube as well as on our Facebook pages as well. There is one question from Dr. Prabha, I think. Cancer survivors group will be very helpful, and they can do motivation counseling for newly diagnosed cancer patients. Any kind of input on this, Dr. Sam?
Exactly. I think it is incredibly important. And two things there, which, you know, it looks is that number one is that you say newly diagnosed cancer patients. And that's what I mentioned before. For many newly diagnosed cancer patients, they're not, what's the word for it? Sorry. They're not given access to support groups. So basically, many doctors don't actually, at that point of time, talk about the idea of support groups that are out there. They don't talk about organizations such as the National Cancer Society of Malaysia. And so it's very important that at that setting where they're diagnosed, patients are then told about the other services which are out there in the community, such as what we provide, or, you know, other NGOs such as MACNA, BCWA, et cetera, have to help them in terms of just not counseling, but in terms of their dietary and psychosocial issues that they have.
Okay, thank you, Dr. Sam. There is another question, and this is how do you think that in Malaysia, primary care physicians actually have a much larger role to play in actually extended survivorship in those phases of survivorship, because we don't have such a good integrated support system, and really the primary care physician becomes the main kind of person to hold the patient through? I
do. You know, at the beginning, you Murali, you spoke a lot about my father in terms of radiotherapy, giving cancer therapies, et cetera. I mentioned my mother. My mother, as I mentioned, is a cancer survivor. She still is a cancer survivor at the age of 91, going to be 92. But she was also a general practitioner for most of her life. And I remember growing up, as a general practitioner, my mother seemed to have a greater position in the community than my father did. Because the general practitioner is really the person who holds it all together. The oncologist, your tertiary, you know, you go to them when you have issues, but the general practitioner, the family physician, is the person who holds the hand from the start to the end for the patient. So it is very, very important that the primary healthcare professional plays a part within the whole matrix of a cancer patient. And only if the primary healthcare physician is part of it, will the cancer patient not fall to the ground, basically. There are the net there to ensure that the patient has that continuous care that is required throughout their life.
Right. Thanks, Dr. Sam. Can we still take some questions? Are you okay with time? Okay. Dr. Sam, there's one from Dr. Sui. May I know the prevalence of early diagnosis and prevalence of late diagnosis for all cancers in Malaysia? I think more as a summative than anything else.
Okay. You can actually look it up. Malaysia, there's two ways you can look it up for Malaysia. You can either look through the global statistics. IARC has a global CAN, which looks at all the Malaysian statistics, or you can look at our own statistics from our NCR, the National Cancer Registry. Unfortunately, with the National Cancer Registry, we're a little bit behind. So I think we're up to 2018. Yeah. So when you look at the prevalence of early diagnosis and prevalence of late diagnosis, overall, if you're looking at all cancers, we're talking about late diagnosis. Most cancers are found within stage 3, stage 4. the cancers that you might find at earlier stages are cancers that we have screening for. So with breast cancer, primarily we have, I think, if I remember rightly, 52% is found in stage 1 and stage 2, 48% is found in stage 3, stage 4. Cervical cancer is the opposite, it's about 50-50. About 50% is found in the early stages, 50% is found in the late stages. Where we can really change things is colorectal cancers, because colorectal cancers are still being found in the late stages. So 60% is still being found in stage 3, stage 4. But we actually have screening tools to be able to find colorectal cancers earlier. And colorectal cancers are the #1 cancers outside of breast cancer in both men and female. So it's an important cancer for us to put more emphasis on.
Okay, Dr. Sound, a couple of more questions. Everyone's kind of energized already now. For depression and anxiety among cancer patients, would they typically present with mild or moderate presentation? Do you think that medication will be the best therapy or counseling? Dr. Sean, Dr. Sound may speak about this, I think, in a bit as well, but so I'm wondering whether, Dr. Sound, you want to take this question after? Okay. There's another question on, mostly cancer patients have a belief that something bad has already happened to them and they will not survive for long. So any ideas on how to deal with this and motivate them? Is there anything else that we can do?
I think the most important thing here is to destigmatize cancer. And that's something that we at the National Cancer Society has been working on for a very, very long time. And the way to destigmatize cancer is, #1 is health literacy. And this comes really from the level of the primary healthcare physician, is that when someone comes and sees you for any other disease, whether it be a cough and cold, et cetera, you should assess the patient in terms of cancer and start talking to the patient in terms of prevention of cancer, early detection of cancer. And this decreases the fear of cancer. And coming from an influencer as yourself, as a primary healthcare physician, someone that a patient looks up to, it makes a huge difference. So it's just not learning from the public or from societies such as ourselves, or there's early detection of cancer, etc. It's learning from the health physician themselves. So that makes a huge difference. #2, of course, is that when they're diagnosed with cancer, is to link them up with support services, such as what we provide at the National Cancer Society, meaning peer support, professional support as well. All these things will make a huge difference in terms of that fear that a patient has, and which will lead to depression in the long run.
Right. Well, Doctor, I've got one more question just before we switch on to the second segment. How can we accomplish getting GPs involved in taking care of patients in collaboration with specialists?
That's a complex question, but I think it really starts with, if the patient has seen the GP first and the GP has referred the patient, specialists themselves should be referring back to the GP. The other way of doing it as well is to request your patient to ask for a referral back to you, or at least to have a document of the cancer care. As we talked about the cancer care plans, etc., is to emphasize to the patient that you're seeing, is to get that cancer care plan written out by the specialist, and then the GP adds on to it as well. But I think it has to be a change of wiring, if you want to put it that way, from both our tertiary as well as our primary healthcare physicians. We need to talk to each other a lot more. We need to discuss this collectively on how we can be better for cancer survivors.
Got it, Dr. Okay, so just before, I think we're going to switch into the second segment, and then we can take the rest of the questions right after. So just in case you need the first code, I'm being very nice, Kongsi Pachai, Chinese New Year President and all. So the first code is really survivorship. So feel free to kind of put it in survivorship. Yeah, so that's the first code. Code word for this session. I'm going to turn the screen back to Dr. Sound so that she can go through the second segment of the session. Then we can continue taking the questions. Thank you so much.
Thank you. Let me see if I can do this again. Okay. So the second part is really looking at survivorship in the primary healthcare setting. Okay. So survivorship in Malaysia, what are the issues? And why is the primary healthcare so important at this point of time? Firstly is that survivors need oversight to ensure that they have a good quality of life and remain in extended survivorship or permanent survivorship. So, at the point that a survivor leaves the acute phase of their survivorship, many survivors get lost. They get lost in that transition I spoke about. So there needs to be someone there to actually provide that oversight, to be able to track what's happening to them. And this is where I believe the primary healthcare setting is set up for this. It is also, number two is that it's also both logistically and financially impossible for extended or permanent survivors to undergo their entire health surveillance for the rest of their life only under tertiary specialists, that is oncologists and surgeons. Oncologists and surgeons are not there for that. That's where the primary healthcare really is set up to do, to be that health surveillance for survivors. Number three, while there is a need for periodic review by tertiary specialists, primary care physicians need to play the most important role in the long-term management of extended survivors and permanent survivors. And I truly believe in this, and I think a lot of survivors would feel the same, that they know there's a trusted physician that they can go to whenever they feel the need for it, whether it be psychological or whether it actually, there is a physical manifestation that requires them to go and see someone. It's very, very difficult for most of them, especially if they're within the public healthcare government hospitals, to be able to make appointments in a timely manner to go and see the tertiary specialist. So this is where the primary care physicians are well set for that timely interventions when required. Number four, as we slowly transition with better drugs and therapies, more and more survivors will become extended survivors and hopefully permanent survivors. And also as we get a more aging population, more people will present and get treated and live with cancer. And, that's becoming more and more true in Malaysia as we move along, especially with those cancers where there are better drugs. So you're looking at your breast cancers, your colorectal cancers, even with lung cancers now, there is extended survivorship as we go along. So it's important that there is someone there to be that net, to have that oversight over all these patients. And that is you as primary healthcare physicians. So what are the reasons that survivors will come to the primary healthcare? We've divided it into four different aspects. The first is non-cancer related issues, your URTIs, your UTIs, your chronic disease management, etc. The second is your long-term and late effects of treatment. So to manage the leftover or new effect of disease. The third is your secondary screening to detect a recurrence or new disease. And the fourth is health promotion and wellness. So your aesthetics, your preventive services. And, your secondary screenings, your especially your health promotion, wellness, etc., also extends to the family members of survivors. So what is the role of the healthcare physician? Most of you would know this quote. God, grant me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference. How does that translate to the healthcare physician? To paraphrase Niebuhr, the primary care physician has the knowledge to look for changes in the patient, the wisdom to know the different reasons for these changes, the courage to investigate and intervene for the patient's best, the serenity to accept when they need help and refer the patient. So, with that in mind, non-cancer health related issues. With a cancer patient, there's not much difference between a person without cancer and a patient with cancer. So number one is that you consult, you examine and treat the patient as you would any other patient. However, in the back of your mind, always keep the cancer in mind. Keep a high level of index of suspicion. And if the condition remains untreatable or unresponsive for 2 weeks or more, always consider getting a tertiary consult. The issue that you have here then, because you've got such high indices of suspicion, investigations might also become more commonplace. So we might do a lot more investigations, which may or may not be required. So therefore, we need to also be careful and watch out for not over-investigating the patient. And that's where the wisdom comes in. It's a narrow line to walk on, but we'll get some right and some we don't get right. But it's important to think about it and have that high level of suspicion. And knowing as well that cancer patients, because of the disease or because of the treatment they've had, are sometimes more susceptible to other chronic diseases, such as cardiovascular, stroke, and diabetes. And I think diabetes is the main point here for many cancer patients. So if we're looking specifically at cancer, and we're looking at the long-term and late effects of cancer, your long-term effects are side effects that began during the treatment and continue long after treatment ends. And many of these side effects are related to the degree of treatment that you have. So it could be surgical, it could be chemotherapy or radiotherapy. And long-term effects generally come from the surgical and the chemotherapy aspects. Your late effects occur after treatment ends. And that's closer to what radiotherapy might give. So both late and long-term effects vary accordingly to treatment exposure and individual host factors. As mentioned, radiotherapy causes late effects with long latency period. So you have radiation-induced second cancers, cardiovascular disease. For breast cancer patients, you have lung fibrosis. So there are many radiation-related diseases which might happen 2 to 3 years after cancer treatment is completed. Chemotherapy causes aging, hormonal deficiencies along the way. These are some that you can look at. And there are some which are very common and some which are quite rare. What is very common that you will see in patients with cancer or in survivorship is pain. And it's one of the issues that is very inadequately and badly managed, even in the tertiary setting, but especially in the primary setting, because patients generally in Malaysia don't like complaining about pain, and they might not even talk about pain. So it's imperative for the physician to actually talk to the patient and question the patient about these effects. So chronic pain can be cancer related, it can be chemotherapy related, radiation related, even hormonal or post-surgical. Interventions, here you can talk about interventions which are drug and non-drug interventions. And we at the National Cancer Society have found, the non-drug interventions that we provide here really provides a lot of comfort to patients and survivorship, just not in terms of the pain, but the overall well-being. So the exercise, the cognitive behavioral therapies, mindfulness practice, meditation, massage, all those things that we do does help in pain as well as your depression. There are other interventions when it comes to chronic pain. So you've got antidepressants, non-opioids, opioids, etc. Some of this can be delivered within the primary healthcare, some would need tertiary. The other issues that you might see, which are very common here, is in terms of infertility and gonadal failure and chemotherapy-induced peripheral neuropathy, especially this with breast cancer patients. So yes, there are interventions out there. Mostly they're interventions which are drug-related. Again, some might require tertiary intervention, but some can be done within the primary healthcare system. These three, fatigue, insomnia, sexual dysfunction, is huge when it comes to survivorship. Fatigue can come from radiotherapy, radiation, immunotherapy, etc., but it can also come from the whole idea of depression as well. Insomnia, the same. So here, you have non-drug interventions, which are similar in terms of your physical activity, your cognitive behavior therapy, psychoeducation therapy, yoga, etc. But for those who have chronic fatigue or insomnia or sexual dysfunction, then yes, drugs are the way to go. And it's very much things, I believe, can be settled within the primary healthcare level and does not have to be pushed to the tertiary. And these are things as well for cancer patients. Generally, they're not things that they are willing to talk to their tertiary doctor about. And they might be more willing to talk to their primary healthcare physician about. So as a primary healthcare physician, you have to be very mindful of these common long-term effects. These are not as common, your metabolic syndromes, your bone loss, cognitive dysfunction, cardiac damage, heart failure, heart dysfunction, etc. But it's the onus is on us to be mindful that these can be the long-term and late side effects of cancer patients. And again, you've got all these different osteoporotic fractures, uterine cancer for tamoxifen, etc. So that pushes it, from the medical or the physical aspects that you might have in terms of your late effects to the whole idea of your psychological well-being. How do cancer patients feel after treatment ends? And here, I think this is very, very important for all of us. Healing is brought about not just by medicine. It's not just treatment which cures you, but all that encompasses the human touch. And the GP, the primary healthcare physician, is the person here. You know, it is the all-important person when it comes to healing. And to me, this quote is just so important for all of us who work in the level of the community, that it is just not treatment which cures, but the human touch. So many survivors will have psychological issues lasting well past the clinical treatment, and they're usually underdiagnosed and undertreated. It's driven by depression, anxiety, PTSD, fear of recurrence, return to work anxiety, financial challenges. And most survivors are on the disease spectrum. I know, in our training as doctors, we are asked to focus on the medical aspects or the physical aspects of a disease, but it is imperative to us as primary healthcare that we have to look at the psychological well-being of our patient as well. So you should screen survivors for distress every time they come in, irrespective of why they come in. And you can use the NCCN distress thermometer. And if it's greater than 3, it is acute distress. And once identified as being in distress, the patient should be managed. Here, I think it's important that in the clinical healthcare setting in Malaysia, if it's a group practice, patients who are cancer survivors should be assigned to a specific doctor and not see multiple doctors. Because there has to be that continuity in care to understand the psychological well-being and to be able to treat the psychological well-being of a patient. So this is the National Comprehensive Cancer Network, NCCN Distress Thermometer. So there's 2 parts of it. One is asking the patient whether they're in distress and asking them to circle the number of how best describes the distress they're experiencing in the last week, including today. As we mentioned, if it's over 3, then the patient is in acute distress. The second part of it is the problem list. And if you look at the problem list, you have, yes, the physical problems, which are on the right-hand side, which is what we as doctors are used to, but they're the other problems which we need to understand as well, so that we can we're able to treat the physical problems and the distress that the patient is undergoing. One is the practical problems, which is their childcare, food, housing, etc. The family problems, the emotional problems, the spiritual, religious concerns. So all that comes under the spectrum of how we should be looking after our patient. It doesn't mean that we have to, as primary healthcare physicians, address every single one of those by ourselves. But it's understanding when do we refer. It's understanding who do we refer to help them with all these different problems as well. So with the psychological well-being, we look at depression, anxiety, post-traumatic stress disorder, fear of recurrence, issues concerning return to work. The risk factors are here. Many of it is the female sex in terms of depression and anxiety. But I think also it's because women are more willing to talk about the issues than men are. So that is something you have to keep in mind in your practice as well, is that people are not going to come out and talk about these things if you don't ask about it. So the onus is on us as the GP to start this conversation, just not to look at the physical problems that they come in for, irrespective of what it is, whether it's cancer related or not, but to actually ask the questions, to be able to ascertain whether or not there are other issues. And for most of this, there are drug as well as non-drug interventions. I would say, depending on how bad the depression and anxiety is, if we can go down the road of non-drug interventions to start with, it would be better. However, there are survivors out there who will need to be started on drugs and will need to have that more frequent assessment in terms of their psychological issue that they're having. In terms of recurrence or new onsets of cancers, recurrence is when a cancer is found after a specific time after treatment. It might come back in the same place or travel somewhere else in the body. And when it spreads, it's still named after the body part where it started. This might, for us as medical people, this might be like learning your ABCs. However, for the cancer survivor, for many people as well who are not literate about cancer, this is a point that people don't understand. A lot of people believe that, if they have breast cancer, it's gone to the lung. They have a new cancer and they have lung cancer. And they will go back to the community saying that, oh no, I have lung cancer now, when actually it's a recurrence of the breast cancer. So it's very important for us to educate our patient when it comes to things like this. There are 3 types of recurrences. The local recurrence, which means that the cancer has come back in the same place it has started. Regional recurrence, the cancer has come back in the lymph nodes, close to where it first started. And distance recurrence, which means the cancer has come back in another part of the body, some distance from where it started, usually in a different organ, the lungs, liver, bone, brain, etc. And sometimes it's difficult to distinguish between recurrence and progression of the cancer. As you know, a new onset cancer is different than that of a recurrence. But again, it's difficult sometimes to know whether it's a new onset of cancer. And the new area of cancer is found to be a different type of cancer from the first time, will be only known through histology. New onset cancers are much rarer than recurrence, but it can happen. And it happens more in those cancer survivors who have survived for a very long time. So a new onset of cancer, if you're talking about breast cancer, sometimes it's difficult to work out whether 5 years down the line, if a patient gets a new breast cancer or it's a recurrence of their breast cancer. But the likelihood after 10 years or 15 years is that it's a new onset breast cancer compared to a recurrence of their old breast cancer. So recurrence estimates. So if you look at, say, bladder cancer, there's a 50% chance of recurrence even after a cystectomy. If you look at breast cancer, there's a 30% overall recurrence. Now, mind you, these are being taken from the National Cancer Institute. So these are statistics which are coming from the US. In Malaysia, I would believe that these statistics are higher. Unfortunately, because our NCR, our National Cancer Registry, hasn't been able to track all this, we don't have statistics primarily for Malaysia. But because our cancers are found much later, the likelihood of recurrence is going to be much higher as well. So I think that's something that we all need to keep in mind whilst looking at these statistics. So if you look at the breast cancer, it's a 30% overall, but it drops if that patient has had extended hormonal treatment. Colorectal, 70% after curative surgery resection. Unfortunately, Malaysia, as I mentioned, because most colorectal cancers are found in stage 3, stage 4, we are already gone into the realms of doing chemotherapy with colorectal surgery. Whilst if you have detected your colorectal cancer in stage 1 or early stage 2, it is going to be curative surgical resection. Head and neck as well, as you can see, there are recurrences, which is local regional. And this is where you'll see a lot in terms of nasopharyngeal, esophageal cancers, and 22% which are distal. Hodgkin's lymphoma, which is quite common here as well. There are relapses, there are recurrences. And you can see that the recurrence rates can be quite high after second-line treatment. And the list goes on as well. You'll be getting these slides, so you can go through them by yourselves as well. And if you look, ovarian cancers, 85% recurrence. So it's important for us as a GP to, when a patient comes to us as a cancer survivor, to understand what cancer they have and the risk of recurrences within that cancer. And if you see prostate cancer, which again is very common, the risk is much later on. It's not as early on. So you're looking at, after 10 years, etc. And thyroid cancers are also fairly common in women here. So there are the risks of recurrence in thyroid cancers. So what do you do as a healthcare professional in the primary care setting? There are surveillance recommendations for these cancers. So such as head and neck cancers, it's physical examinations every 1 to 3 months for a year, then 2 to 6 months every 2 to 5 years, and annually after 5 years. Many of these surveillance recommendations are being done at the moment on the tertiary level in Malaysia. But some of these can be done at the primary healthcare level. And it's important that we understand what we need to do for the surveillance of the specific cancers. So if you look at breast cancer, you're looking at a physical examination every 3 to 4 months for 3 years, then every 6 months for 2 years. So at a tertiary level here, a tertiary physician might see the breast cancer patient in the first year every 4 months. In the second year, every 6 months, etc. So the gaps in between are where the primary physician, healthcare physician, our GP, should be looking at the breast cancer patient as well. So it should be both tertiary as well as primary healthcare that looks after the patient. Same as you can see with colorectal cancer, it's quite intensive to start with, every 3 to 6 months for 5 years. Testicular cancers, you follow up with the guidelines, etc. So there's certain cancers where it's very intensive in the first couple of years. And this is where the GP has a role to play in terms of the surveillance of these cancers. And by ensuring that the GP, if the GP is involved in it, it actually ensures that the patient doesn't fall through the net, and that when symptoms are seen and are felt, there's a timely intervention made for that patient. So for new onset cancers, as we mentioned before, having the first cancer increases your risk for secondary cancers. So this is a list of secondary cancers that you might get in cancer patients. And these are things that we have to look out for as well. So when you look at lung cancer, there's a slight increase in terms of risk for colorectal cancers. And there is also a risk for breast cancers and esophageal with radiotherapy. So depending on the type of treatment that patient has had, that risk for cancer might be much higher or lower, depending. So for colorectal cancer, there is a slight increased risk for prostate cancer. And for colorectal, for women, you can see there's a higher risk for lung cancer, breast cancer, uterine cancer. And for breast cancer, the second cancer that you have, again, you'll see an increased risk for lung cancers, slight increase for colorectal, but you'll also see an increase here for ovarian cancer and uterine cancer. And of course, having a second breast cancer as well. So note, these are new cancers. They're not recurrences of the old cancers. Head and neck as well. You'll see a 3-time increase in terms of lung cancers in people who have had head and neck cancers. And for uterine cancers, you'll see a huge increase in breast cancer. So this is a double, and colorectal cancers. And Hodgkin's disease as well. As you can see, there's a huge impact in terms of women when it comes to lung cancers and leukemias. Lastly, I'd like to just go through a little bit on health promotion and wellness. So the role for the GP in health promotion and wellness is in behavior interventions, and this needs to be monitored regularly. It includes weight management, physical activity, smoking cessation, reduced alcohol consumption, healthy diets. And all these drives the lowering of risk associated with recurrence or new cancers, as well as keeping survivors fit. And it's truly part of the primary healthcare physician's arsenal. The last bit, as I mentioned, previously, is that as a primary healthcare physician, you're not left alone out there. There are others around you to support you in looking after the cancer survivor. And what I'll go through here now is a little bit of how NCSM can support you in looking at survivorship. So the first is that we have a cancer information service. And this cancer information service was set up to empower and support people affected by cancer, as well as the general public, as well as physicians. So, you can call our helpline, which is 1-800-888-1000. And you can speak to one of our specialists who can provide you with up-to-date evidence-based information on cancer resources, financial aid, psychological support, preparing for surgery, healing, palliative care, as well as diet and nutrition. So we have information out there for you and for the patient as well. The clinical psychology services we have is non-medical. So it helps individuals of all ages and backgrounds who encounters psychological, emotional, or behavioral interpersonal issues. So we have an in-house specialist, and she can deal with a range of mental problems that cancer survivors have. And we can work with you on looking after your patient while they're under your care. We also have counseling services. and the counseling services are individual as well as group for adults, youth, couples, and families. It specializes in handling stress-related interpersonal relationship issues, even resolving marital conflicts and anger management, improving your self-esteem, which is a big thing when it comes to cancer survivorships after having a diagnosis of cancer, and also in your career development. So again, these counseling services can work hand in hand with your primary healthcare service provided. We also have dietetics and nutrition services. We do dietetics assessment interventions for adults and children with health issues and related to cancer and non-cancer as well. So we can come up with a personalized diet plan for people with cancer. So all this, again, assists you at the level of the primary healthcare physician. And for children with cancer, we actually have play therapy services. So the play therapy services help children, teenagers, and young adults indirectly communicate their feelings through playing with toys and materials. And it's a form of language which allows them to express their feelings and work their way through difficult emotions and fears. So all these are available at the National Cancer Society to help you and to be part of the arsenal that you have to help cancer survivorship. So in conclusion, there are going to be more and more survivors. And the primary healthcare physicians need to be able to manage these survivors, optimize their long-term follow-up, and keep them fit and well. And again, as I mentioned, you don't have to do it alone. You know, there are organizations such as the National Cancer Society of Malaysia to help you assist people in their survivorship. But where your role is integral is to reduce the risk of recurrence and new onsets of cancers. So thank you.
Thank you very much, Doctor. I think we have some questions, if you are okay to take them. I think it's a very relevant, insightful presentation. And I think more importantly, I hope that it's given some of our colleagues an idea of how to kind of reach across to us, as well as the roles that they can take on in managing cancer patients or survivors or for the rest of their survivorship journey. Doctor, there was a question on, do you think that the primary care physician actually needs to act as more or less a patient navigator? And really to the back of that, it's like, what really is like this patient navigation services that a patient actually needs in cancer?
Okay, yes, definitely. I think the primary healthcare physician should be the patient navigator. And the patient navigator basically is the person who holds the hand of the cancer patient throughout their journey, is to ensure that the patient moves seamlessly from the community to the primary healthcare to the tertiary and back again. And is able to, as we mentioned, have that oversight over that patient, not just in terms of the medical issues, but also the psychosocial issues that the patient has. So yeah, so it's being by the side of the patient throughout their journey. And I think that really is the role of a primary healthcare physician. When the primary healthcare physician, years ago, even when you go back into the 17th, 18th, 19th century, et cetera, they were always the trusted person that the patient went to, that the primary healthcare physician spoke for the patient. And that is what all that patient navigation is about.
Okay, Doctor, thank you. Doctor, there's another question on when we're doing routine screening for the patients, do you recommend tumor markers like the labs do?
No. I would say, there are certain cancers such as your prostate cancer, which might require PSA. But that comes after guidance from the doctor themselves. There has to be, it's not done just for the sake of being done. There has to be a reason for doing the tumor marker. And in terms of screening of new cancers, it's not a recommended test to do. In terms of follow-up of cancer patients, that's different. In terms of follow-up of cancer patients, there are specific tumor markers. Yes, you need to check as you go along.
Right. Also, just to kind of interject, Doctor, and kind of clarify, there's a few queries on whether the National Cancer Society's services are available nationwide. The answer for that is a yes, Doctor, because since COVID, we've actually put in telehealth services. So all the services are available anywhere in Malaysia. They're being deployed nationwide as well. So feel free to kind of call us, arrange an e-appointment, and then whoever those specific specialists that you need to get to, they'll kind of get online to you if you cannot get them face to face or you're outside KL. There you go. Doctor, there's another question on okay, what is a good method a GP can approach when engaging a patient to discuss about cancer?
That's a hard question. I think it really depends on your patient as well. Whether you're talking to a patient who already has had cancer, or you're talking about a patient in terms of talking to them about their risk about cancer. And I think in terms of talking about their risk for developing cancer, you can start in terms of a general sort of risk assessment, because many of the risk factors for cancer are also for other chronic non-communicable diseases such as heart disease and diabetes, etc., etc. And there's less fear out there on talking about heart disease or diabetes compared to talking about cancer. So if you start indirectly in terms of talking to people about, okay, you know, you're a certain age, there are certain risks for development of these diseases, and then slowly honing in onto cancer, and specifically into cancers which are, one, preventable, or two, for those which have early diagnosis. I think in terms of talking to a patient about their cancer diagnosis, it's always, I think it can be difficult talking to a patient in terms of their cancer diagnosis because of the emotion and the psychosocial issues surrounding it. And there has to be a degree of empathy when it comes to talking about it, and it has to be non-judgmental. I think that's very important. It's not, you know, saying, oh, why wasn't this done? Why wasn't that done, et cetera, because it really gets the cancer patient questioning whether or not they've done the best thing they have in terms of their cancer treatment they've done. And also the other thing I'm sure that all of you will be faced with is a lot of cancer patients who decide to take alternative therapies. And again, with cancer patients who have decided to take alternative therapies, we cannot be judgmental. We need to talk to them. We need to be able to engage with them on why conventional therapies that we provide are important to them. And that's really education. And that is really gaining the confidence of that patient that what you want to do for them is in their best interest and not for monetary reasons, et cetera, which is the big thing that, you know, is out there, that people feel that, especially with cancer, we're just out there to take as much money that we can from them. So it's getting that engagement and getting that trust of that cancer patient. That's why I always say it's very important in the GP practice, especially in group practices, that a cancer patient sees the same doctor every single time. So you build that relationship with the doctor, with that patient.
Dr. Shaun earlier asked this question, and I asked whether we could re-ask it at this point in time. Dr. Saunthari, for depression and anxiety among cancer patients, usually would they present with mild or moderate presentations, and do you think medication would be the best therapy or counseling?
Okay, I think I answered it a little bit in the sense. I think a lot of the depression and anxiety comes from not understanding what the cancer is about, or not being able to re-normalize their lives again. So for much of that, it's really having someone to talk to and regaining that identity that you have as a person, and not just being a breast cancer survivor or a colorectal survivor. It's being who you are as me, Saunthari, or you, Murali, or someone. It's being the person with a life around them. So for a lot of anxiety and depression, I don't believe medication is required, especially if you address it from the point the patient is diagnosed. If the patient does not get the necessary support throughout the treatment, then yes, it can be quite bad in terms of the anxiety and depression that patient feels. But if you address it from the day one that they're diagnosed and you give them the relevant support, they journey much better. Of course, you also have to understand why the anxiety and depression is there, whether it's from the medical aspects of it or whether it's from the community, whether it's from the practical aspects of it. Do they have the financial, do they have enough finances for their treatment? Is there support within the household, etc.? So it's important to address where the anxiety and depression is coming from before we just prescribe medications for it.
Got it. Dr. Sam, one more question, and this is on how much of empathy do we advocate to patients, and how much empowerment for the entire journey?
I would say as much as you can. Treat your patient as you would like to be treated. Take out the medical degree from the front of your name or the back of your name, whatever, and put yourself in that patient's shoes and see, and then work out how much empathy and how much hand holding or empowerment that you think that patient needs. And to me, every patient needs empathy and needs empowerment. You might feel that the patient hasn't had the education. You might feel that the patient is too elderly. I don't believe in that. I believe every patient should be empowered, irrespective of their age and their level of education, in terms of their cancer, so that they can make decisions for themselves. Now, note, patients might not make the same decisions as doctors do. We tend to look at the disease and say, okay, I'm going to do A, B, and C so that I can cure this disease, or so that, this patient will live another 3 months or 6 months, etc., etc. A patient might say, no, that's not important to me. It's not important to me that you cured this disease. It might be more important that I live for the next 6 months within my community, within my family, so that I can see my daughter get married, or my son go to school, etc., etc. And that's what's important to them. And if we can give them that, then that should be the focus of what our treatment is. So patient empowerment is very, very important. And patient-centric care is important.
Got it, Dr. Sam. Dr. Lakwinda, who asked, I think, the last question, has kind of put their hand up. Could I just ask them to unmute, maybe just to ask a quick question if you need any more clarification? Oh, okay. So, so then Dr. Lakwinder, that means no problem, your hand can be lowered, yeah? Okay, no worries. Thank you. Dr. Sound, just a couple of more questions if you're available to take them. Is that okay? Okay, there's one which is a bit off topic today, but I'm just going to put it on since we have everyone in the room. Is self-breast examination enough to detect early breast cancer for women aged above 40? Do you need mammography or something else?
Okay, when you're looking at gold standards, then we would say, yes, you should go for mammography. But if you look at WHO guidelines, WHO guidelines has stratified interventions depending on the economic availability. I mean, the economic one, and two, the availability of investigations within the country. So if your mammography center is going to be 100 kilometers away from where you live, and you don't have transport to be able to go that 100 kilometers, then yes, a self-breast examination is imperative for any woman. However, if you live in Kuala Lumpur and it's economically viable, which it is, because under the government, there are subsidized mammograms, which PPKN, National Cancer Society, other hospitals do as well. We do it free of charge for those who are financially constrained. There are opportunities for you to go and do a mammogram. So a mammogram is definitely much better in that setting than doing a breast self-examination.
Okay, thanks, Dr. Sound. There's one more question. Financial constraints is a problem in today's oncological treatment. Can NCSM be able to render help to get financial support?
Yes, we can render help in the sense that the National Cancer Society has certain services which are subsidized, which we can offer you. And secondly, if you call our CIS, the helpline, we can put you in touch with the organizations which can provide financial support.
Right, and also maybe just to add on to what Dr. Sound is saying, Dr. Yu, in many cases, our CIS colleagues also help patients to actually make the actual applications to the relevant institutions in terms of if they have challenges in getting forms together and all that. They help them navigate through that as well as in hospitals in which patients are not available they need to buy medications when they are not available in formulary or provided free of cost to the patient. The society can help to negotiate with the pharmaceutical companies that are relevant to kind of get prices for patients as well. So that's two other things that we can do for helping in kind of navigating financial challenges. Will do. Okay, so Dr. Sound, I think we have finally kind of completed all the questions. So thank you very much for taking up the time and being with us this morning, and that lovely presentation as well. Okay, just a couple of housekeeping questions to be answered, ladies and gentlemen. First is in terms of the second code word, and the second code word is recurrence. Recurrence. So just be nice and give you the first word was survivorship, and the second code word is recurrence. And in your emails, which have the link for this session, you already have the link to put up your attendance for CME points. So you can go ahead and do that. Just look back at the email that was sent to you. Also, the CME kind of application is still open for the rest of the week. It'll be still open for 1 week. When we put up the link on YouTube, we will also put up the link for CME points so that you can watch at your own leisure for colleagues who haven't yet watched it, and then you can apply for your CME points. So that's still available. For non-medical doctors, you can apply, you can continue, just fill in the same form for CPD points, and we'll be very happy to give that to you along with an e-certificate. The two questions for which immediately I'll answer as well. First is the YouTube link will be right after this. Just give us about 20 minutes or 30 minutes or so, and then it'll be up in YouTube. And so please go on the National Cancer Society Facebook page or our YouTube channel, and you can review the recording. Also, we will resend the slides to you all right after this onto everyone who has registered for this session. So I think, again, thank you very much for joining us today, and I hope you all have had an insightful session, and we'll see you again next month for the similar kind of session. Next month is colorectal cancer, and I think joining us next month will be Prof. April, colorectal surgeon and the Dean of University of Malaya, to speak to you ladies and gentlemen on colorectal cancer and primary care. I'm just going to repeat the code again because I have some queries on whether someone has, whether we have the code. The first code was survivorship, and the second code is recurrence. So ladies and gentlemen, thank you very much for those still celebrating Chinese New Year. Happy Chinese New Year once again, and we will see you next month. Thank you very much.